ICD-10 and Prognosis. Welcome to the Transitioning to ICD-10 webinar. We've all been on this road to ICD-10 now for quite a while, and now that it's just around the corner, the purpose of today's webinar is to help you get prepared in advance, as well as to show you the enhancements that Prognosis has implemented to help you manage your ICD-10s moving forward. Our session is broken into 3 segments. First of all, we're going to look at how you can prepare in advance, doing a current analysis of your ICD-9s. We have released a couple of new tabular reports that are designed to help you identify the most commonly assessed ICD-9 codes within your practice, and these reports are both with or without patient content. The intent here is for you to be able to develop an internal crosswalk or a superbill based on these frequently used codes, so that there is a minimal interruption in your workflow as you go through your learning curve. Secondly, we're going to look at some electronic transition tools that we have implemented both in EMR and billing. And these are primarily designed to help you manage your master files. For those of you who use auto-populate functionality, these are designed to help you modify those now to an ICD-10 equivalent so that there is, again, no disruption in your workflow starting October 1st. We also have tools available at an encounter level, and these will help you map your ICD-9s as you go on a case-by-case basis. Now, as of October 1, the date of service is what will be the determining factor as to whether you are working with an ICD-9 encounter claim or an ICD-10 encounter claim. So we're going to look at the enhancements we've implemented as to the ICD-10 searching. So first of all, we're going to take a look at that ICD-9 to ICD-10 crosswalk. We've implemented 2 new tabular reports on the EMR side. And as with all tabular reports, these are based on a date range, and you of course can sort them in the desired sequence. For instance, you might want to sort them by the count of diagnoses, or by the description, or by the code. The first of these 2 reports is the count of ICDs per given period list. And this does not have patient data in context. It is simply an overall count of ICD-9s that you have been currently assessing during the date period you specify when you generate the report. As you see here, it is quite simply just a listing of the diagnosis code, description, and a count. That count representing how many times you uniquely assessed this diagnosis during the reporting period. The intent here would be for you to identify the most frequently used ICDs, so that if you do use some sort of an encounter form or superbill that has your ICD-9s on it by default, you can go ahead and update that to have your ICD-10s. Now, the equivalent report with patient content is your diagnosis-wise patients in a given period. And you see here that it is basically the same report, except instead of a count, it has patient content. You see there that you have a patient name and an encounter date on which that diagnosis was assessed. The purpose of this report would be for those of you who would like to go ahead and start updating patients' past medical history before they have their next appointment after October 1st. Come October 1st, anywhere on a patient's chart that a diagnosis is referenced, it will have to have both an ICD-9 and its ICD-10 equivalent. So many clients do use some sort of a superbill or an encounter form that has these frequently used diagnoses on it. Through our recent conversations with clients and their feedback, some of them have provided samples or examples as to what they're doing in their own practices with regards to updating their form, so we thought we would pass those on to you. Even though these are not part of Prognosis, they may work to your benefit within your practice. So first of all, here we have a simple example. And again, those of you who have some superbill or encounter form in your office, this may look familiar, where you quite simply have the diagnosis listed and the diagnosis code. So we've taken just a few generic headache codes and showed you how you have the existing ICD-9, and you can now map it over to the equivalent ICD-10. An expanded example of these same codes, notice, is a lot more substantial. First of all, clinically speaking, because of meaningful use, wherever a diagnosis is referenced now on a patient's chart, it must have a corresponding SNOMED, and then of course as of October 1, that will also have an ICD-10. SNOMED is not applicable on the billing side. So you see just taking the generic headache. And this again is just a small snippet of what your Superbill would actually look like, because you of course would be tailoring it towards your patient population and the diagnoses that you are seeing and assessing. But just as an example here, how a simple 7840 on the ICD-9 side of things can be different ICD-10 SNOMED combinations. Moving down, we see the same with migraine, and you notice because ICD-10 requires you to go out to the specificity, we see for migraine, for instance, it can be with or without aura, persistent and non-persistent, intractable. You've got things that may be pregnancy related, cluster headaches, and so on. So again, if this is something that you use in your practice, this is certainly not a requirement, but it is just a suggestion to help you get through that curve starting October 1st. Now moving into the prognosis implementation of various tools to help you identify your ICD-10s within the system, if you don't use an encounter form, for instance. We have implemented the hyperlink tool. Now a hyperlink is a blue underlined label. You're probably familiar with this just through any internet application where websites are usually hyperlinked to open up additional data. That is what we are using to help you map your ICD-9 codes to a matching ICD-10 SNOMED combination. So on all screens where your diagnosis is available, the ICD-9 code is going to display as a hyperlink. And it will open up a filtered search which contains possible ICD-10s for that particular code. Now throughout the system, you're going to see this hyperlink at two levels, the master file or system level, and then also at the encounter or claim level. So it is available on numerous screens. We're going to first of all look at the new ICD-10 transition tool, and then your preferred lists, your complaints master, and your vaccine masters. And those are the three master files that feed your assessment if you use those pre-population functionality. Now health maintenance and patient education also supports ICD-10. They do not, however, use the hyperlink tool to help you revise them, so we will take a look at that at the master file level. Now, if you decide not to update your master files in advance and you just want to do it as you go, as your patients are coming in, the hyperlink tool is also available for you at the encounter level. And if you have appropriate rights, it will prompt you at that time if you would also like to update the underlying master file at the same time. Now this is going to be available on the encounter screens wherever you can search for a diagnosis, whether it's the plus sign icon, the magnifying glass, the assign ICD button. And then on the claim side, we will have the hyperlink available within the ICD table on the claim details page. Now the way the hyperlink works is regardless of the screen that you execute it on, when you click it, it is going to auto-invoke one of two filtered searches. And that filtered search is either going to be your preferred or your standard search. And it is filtered by the ICD-9. By now we assume you've gone through all of your clinical education as regards ICD-10. So you're well aware that approximately 10,000 ICD-9s that we've had for years has now turned into upwards of 70,000 ICD-10s that we're all going to have to start learning. So to help minimize that search time, these filtered searches will limit the indexed returns to only the specific code you're searching for. Initially, it's going to try to default to your preferred filtered search. So we see here on our assessment, I've highlighted the acute kidney failure. You'll notice that the ICD-9 is a blue underlined font, and when you click that 584.9, it is going to open up the IMO search filtered to only that one ICD-9. Now in this case, it defaults to the preferred. This of course will vary from practice to practice depending if that code is populating off of your preferred list. And because ICD-10 is so much more extensive than the ICD-9, you may have it referenced more than once. As we see here, even though it's the same ICD-9 all the way down, the SNOMED and or ICD-10 are unique. It all depends on the situation. But this is why the preferred list now will allow you to populate the same ICD-9 more than once. Now, your preferred list does include all three levels. The My Preferences, which are specific to a doctor's login, your doctor's specialty, and your clinic preferences, which are available at a system level to all users. Now, if you do not have the code defined on your preferred list, then the system will default the standard search. So in this example, I have the diagnosis code 650. This time when I click the hyperlink, notice it opened to my standard, and it's going to actually give you an alert to tell you it's navigating to the standard in that scenario, which is the indication to you that this is not on your preferred list. So most of the time, if you have your frequently used codes on the preferred list, you won't have to go through the standard. But if it's not there, then it will auto-invoke the standard search instead. And of course, the standard search does have the keyword search for you, so that if you need to expand it further, even though it's indexed to only that particular ICD-9, if you do want to narrow it down by the condition, by the chronicity pattern, or if you happen to know the root of the ICD-10 code, you want to search it further and a little quicker, you'll be able to do that as well. So it's either going to invoke your preferred list if the ICD-9 has been defined there, or it will invoke the standard search for the ICD-9 specifically that you have clicked, and both of those are going to be filtered to show only the potential SNOMED ICD-10 for that ICD-9 only. Now looking at the system level in our master files, the master files is what auto-populates your assessment if you are using those particular functions in your practice. First of all, we have a new screen that we're introducing called ICD-10 Transition. Now this is going to display only the primary predefined ICD-9 codes in each of those applicable master files, such as your preferred codes, your complaints, your vaccines. Now as regards your complaint master, you can have both primary and optional ICDs. Optional ICDs are not part of the transition tool, but we will see that a little bit further down on our encounter level, where you will also be able to update those. Now, if your master files do not currently have a predefined ICD-9 defaulting, and you will decide now you would like to use that function, you will have to update them directly under the configuration menu. This utility has two purposes. It applies now for transitioning, but it also will remain visible after October 1st so that you can manage your ICD-10s moving forward in case you decide you want to modify it and change the ICD-10 that you chose initially. It is important to note that this does require you have update permissions on your user profile to the applicable master files. Some of you may have the rights to update the assessment on the encounter screen or update the chief complaint on the encounter screen. But if you do not also have the corresponding update permissions to the master file, which is often reserved to the IT administrator or office manager level, then you will not be able to use this function. Otherwise, it is applicable to all prognosis users. So looking at the transition tool, it is a tabular screen, and you'll notice here that we have 4 tabs across the top, defaulting initially to your preferred. Now this is your clinic preferred. And as you see, the master file looks pretty much the same. It simply has the code, the description, and then it also has a count as to how many times you've assessed that diagnosis, in case you want to do that kind of an analysis on your preferences. It is bidirectional, so you see the hyperlink exists in both screens. You also notice the hyperlink is still present even after you've assigned the code. Now, in the upper left, we have the specialty drop-down. This is because at a clinic level, those of you who are a multi-specialty practice are also able to define your preferences at a specialty level. So if you have multiple pediatricians, multiple family practice, multiple OBGYN providers, and they don't necessarily need their own personal preferences, but they do like a preferred list that is separate from the rest of the practice, you can define it at that specialty level. So this will allow you to transition both clinic preferences as well as doctor specialty preferences. Moving to the complaints tab, this is of course coming out of your chief complaint master or workflow complaints. When you do patient intake and you assign an HPI template as the chief complaint, if you have predefined this primary diagnosis under that complaint, that auto-populates your assessment so that when the doctor gets to the assessment screen, the diagnosis is already present. You see that it is hyperlinked both in the master file as well as on the transition tool. You can opt to modify it in either location and it will bidirectionally update both screens. Now at this level, these optional ICDs that are also predefined to the complaint are not part of the transition tool. This is for the primary ICDs that auto-populate only. Those optional ICDs are available as a shortlist for the doctor on the assessment, but they do not auto-populate. The third tab is your vaccine. When you administer a vaccination from the patient's face sheet, if you have predefined a diagnosis on that vaccine master, it will auto-populate the assessment. Now if you notice in my transition screen, I only have 4 listed. But here on the right-hand side in my vaccination search, I have far more than 4 vaccines in my database. The others that are in my database vaccine master that are not on my transition tool vaccine tab simply don't have an ICD defaulted yet because it is not a requirement. So again, this would only be if you are using that mechanism where you have predefined the diagnosis that you want to auto-populate your assessment. And then the final tab is Doctor Preferred. Doctor Preferred ICDs is different from that first tab, which was Clinic Preferred, in that your doctor preferences are unique to his or her ID only. You'll notice the green line here is pointing to Preferred List for Sheldon Cooper, MD. So if you log into Prognosis and you're not a physician, this tab will actually be grayed out on the transition tool. It'll be disabled. If you log in and you are a provider, you will have access to this tab, but unless you have defined My Preferences under Configuration My Preferences, then it'll just simply be a blank screen. Now, as mentioned earlier, you do have to have the appropriate configuration rights for updating these values. If you do not, you will get an error such as this stating that no modification is allowed. Now, even though you may have a clinical role primary, you can always have the permission added to you, but that is a local decision. So again, the ICD-10 transition tool is simply a single screen utility that accesses all of these individual master files that can otherwise be accessed directly through configuration. It will remain a hyperlink even after you have mapped a code so that if you want to change it in the future, you'll be able to. Now, I mentioned on the onset that health maintenance and patient education also support ICD-10, but not in the hyperlink mechanism. You'll notice here on my health maintenance, there is now an ICD-10 radio button choice as well. So when you define your protocols, you can trigger them at a 9 or a 10 level. Now that the 9 has to be mapped to a 10, the 9 is still in reference and still exists at the patient level. Therefore, it is still valid. So you can choose not to worry about this. You will still be meaningful use compliant moving forward because that ICD-9 is still valid. It will still be referenced inside the database, or you can opt to redesign the protocols at the ICD-10 level. Of course, there may be a hybrid scenario where the ICD-9 has become so specific in the ICD-10 world that the initial protocol no longer works. So you may have to create a new one for the ICD-10, but that will be at your local discretion. In the meantime, the 9 is still valid, and therefore the protocols that you have are still active. We are not disabling them. Same is true on your patient education. We've added a new trigger of ICD-10 range so that when you create, if you so desire, your education, it can be based on the ICD-10. However, the ICD-9 remains valid. So those are your master files. Now we're going to look at the encounter level. If you opt not to update those master files in advance, then starting October 1, all of your auto-populated diagnoses will still be the ICD-9. That means you will have to update them on the encounter level as you go. But when you do that, at various levels, you will have a prompt asking you if you would also like to simultaneously update that master file. Initially, we're going to look at the past medical history. Of course, come October 1, all of your existing patients, this is what their face sheet PMH will look like. All of their ICD-9s are going to carry forward as a hyperlink. Notice that the hyperlink in this scenario, however, is not always blue. Blue is the default color for a standard ICD-9 that needs to be mapped to an ICD-10. However, if you do Medicare Advantage HMO patients and you are therefore subject to the hierarchical condition coding, HCC, when we started supporting that, we implemented it as the hyperlink function. So initially, the ICD, the only time it was hyperlinked was an indication that it was a Medicare HMO HCC diagnosis. and it would either be blue when it was valid or red when it had expired and needed to be reassessed. We still support HCC, so for those of you who are utilizing that feature, you will still have that function. The only distinction now is that the hyperlink, when it is valid, will be green instead of blue. Bottom line, every ICD-9 after October 1 is a hyperlink. Regardless of the color, it needs to be mapped to a corresponding ICD-10 SNOMED combination. Now please note, if you are using the auto-populate from past medical history, it is at your local discretion if you want to update the history ICDs. But if you are going to auto-populate from here to the assessment, you will want to do it here so as to retain that original assessment date. Transition of care, when you go to add a new diagnosis, it has to be mapped also to an ICD-10. So the hyperlink is available before you reconcile medical history. Moving down the encounter to our assessment, we have 4 scenarios we're going to look at. And these are dealing with this auto-population of the diagnosis from one of those master files, as we just discussed on our transition tool. Our first scenario here is when the diagnosis auto-populates to the assessment from the chief complaint. Now again, local processes may vary here because you may not use this function, or you may have only predefined certain complaints with diagnoses, so it may default in some cases, not in others. Either way, all of your diagnoses in the assessment screen after October 1 do need to be mapped to an ICD-10. So in this case, if you had already updated the complaint master to an ICD-10 equivalent, it would have auto-populated correctly. You would not have to do it at this level. But if you opt not to do it in the master file level in advance, then you can do it now on the encounter level. When you choose the ICD-10 on the assessment by clicking that hyperlink, it is going to prompt you. Would you also now like to simultaneously update that master file? Now you do have to have the appropriate access because again, in many practices, a physician will assign his nurse or his medical assistant as a scribe. And that scribe may have full clinical access, but may not also have the administrative access under the configuration menu. If that's the case, you will be able to update the encounter only, and you will not receive this prompt to update the master file. Meaning, unless the master file is updated directly, it will always pre-populate the ICD-9, and on every encounter, the scribe will have to update it, but will not be updating the master file. So that would be a local decision. Again, if you want to make sure that the user updating the clinical side also has the administrative side, or update the master file, whoever is the administrator, so that clinically the ICD-10 is what pre-populates. Now on the transition tool, we mentioned that for your complaints tab, it was primary ICD only. But you also have the ability of assigning optional ICDs in your complaint master. And that is what populates the C button here on the assessment, so that in cases when that principal diagnosis that auto-populated needs to be changed, the doctor has a predefined short list of other appropriate alternate ICDs from which to select. Now, of course, again, the hyperlink is bidirectional. So if the master file optional ICDs have already been updated, the ICD-10 will be chosen through the C button, or the physician at this point can update it through the hyperlink and will also then be prompted, if the appropriate configuration rights is on his profile, to also update that underlying master file. Third scenario of the assessment is vaccine. When that vaccine gets administered from the face sheet, if the ICD is predefined in the vaccine master, it auto-populates the assessment. You can modify it, be prompted to update the master file if you want and if you have the rights. So all 3 of those behave the same way. If the master file is updated in advance, either through the transition tool or directly under configuration, it will auto-populate the ICD-10 from the beginning. Fourth scenario is medical history, and it operates the same way functionally. However, notice the caution in the pink bubble. When you are choosing to update a patient's past medical history from the encounter assessment, it automatically updates the past medical history. However, it also updates the assessment date as of that date of service. Now, in the case of your Medicare HMOs, this is great because when that hyperlink is read, which means the HCC has expired and you want to update it as having been reassessed, then you do want to reassign the correct date. But let's say I'm your patient come October 1st. You diagnosed me with diabetes 4 years ago. You do not now want to update me to an ICD-10 on the encounter assessment because it'll look like you've just now assessed me with diabetes. Whereas if you do it through the past medical history directly, you're able to backdate it or retain that original assessment date while mapping it to the ICD-10. So that is at your discretion. You can certainly do it from here if you want. It will assign the encounter date of service, however, as the assessment date for that diagnosis. Now, leaving the assessment, we have our CPOE module, which includes lab radiology. You can assign, of course, an ICD to your test level so that that diagnosis prints on the requisition or interfaces if you have an interface for your lab radiology orders. Now, we've been supporting this for quite a while. You'll notice there in the pink box, there's a property that allows both 9 and 10. We've been certifying all of our vendors, of course, through this transition. And many vendors, in order to certify, needed both 9 and 10 codes present on their requisitions. So you may already be past this particular learning curve. But if not, notice that when you do go in to assign the ICD, it is hyperlinked if it is not yet mapped. So you can map it at this point and then complete your requisition. Now, the prescription piece of CPOE functions similarly, but is distinct in that you will not have the hyperlink function here. This is a little unique from the lab radiology in that when you write a prescription, whether it's a new prescription or a refill, the ICD must already be mapped. It must already have an appropriate ICD-10 code if you're prescribing the drug. Whereas in your lab and radiology, you may be ordering the test for the sake of obtaining that diagnosis. It may not be known yet. Plus, you may be doing your lab and radiology in a pre-op scenario. So that allows you to assign the diagnosis outside of the encounter. Your prescription, however, is based on an already known diagnosis, so the hyperlink is not available to you here. If it is not yet mapped, as we see here in our alcoholic gastritis, you would have to go to the assessment or past medical history, map that ICD, and then write your prescription. For those of you who use doctor forms in your practice for the sake of your assessment, there's 2 scenarios here on the doctor form. This top scenario, if you use this design where on your doctor form the diagnosis exists as a checkbox, you do not need to worry about having your form redesigned. It is going to automatically reflect the hyperlink after October 1, as you see here. In any other type of element design, however, if you have a master file search, a pick list choice, a radio button design, a text field, those will not support hyperlink. After October 1, you can still use this to update your assessment, but you will be updating it with the ICD-9 only. Therefore, you would have to then end up on the assessment updating the ICD-10 equivalent. The one exception would be if you are using the current IMO master file search. The original master file search prior to version 3 would need to be modified, but the current IMO search does support hyperlink, as we've already discussed. So this is all workflow decisions based upon the scenarios in your practice. PQRS also supports ICD-10 with the same hyperlink function. There's one distinction here, however. The ICD-10 is where your hyperlink will be, and you will be choosing the ICD-9. Whereas in all of these other screens we've looked at so far, it was the ICD-9 that was hyperlinked and you chose the ICD-10. PQRS is reverse, but they do have both the 9 and the 10 codes once you get inside the PQRS diagnosis table. Through all of these screens, you are going to have validation alerts. For instance, if you invoke the IMO search and you have not yet updated your preferred or your custom tab, you will not be able to assign that to your assessment or your claim. You will get prompted, as you see here, that you need to map it first to an ICD-10 before you can assess it. Same thing on the assessment screen of the encounter level. If that diagnosis has auto-populated from the master file or from your doctor form and you have not yet mapped it yet, you will have to map it here, or you cannot save your assessment and plan data once you put that assessment screen into data entry mode. If you do not have the appropriate administrative rights and you are trying to update the hyperlink, you will not be able to. It will prompt you accordingly. If you try to close the encounter without having already visited all of those other screens where it's hyperlinked and you have not yet mapped it, you will not be able to close the encounter or create the claim. Remember that the default logic in prognosis, if you have both billing and EMR, is that the claim gets created automatically when the doctor closes the encounter, provided diagnoses and/or procedure codes are present. Bottom line, on an encounter level, if you have not mapped every ICD-9 in reference to an ICD-10 SNOMED, you cannot close that encounter or create the claim. So it's your choice if you want to do it at the master file level in advance of October 1 and then let everything auto-populate correctly from the beginning, or if you want to update it individually as you go on each screen of an encounter, and when prompted, update the underlying master file. It will also validate if you have duplicates. Now on the clinical side, a duplicate is determined by the 9, the 10, and the SNOMED, all three being the same. If one of those three values is unique, it will not validate as a dupe. Now looking at the billing side for a few minutes, the changes over here on billing are not as great as we just discussed in EMR, primarily because, as I mentioned on that last slide, you can't even create the claim to begin with if it doesn't have the ICD-10 already present. So the majority of the time, you're going to have your claim drop correctly with the ICD-10. However, the hyperlink is supported on the claim level. So first of all, we're going to look here at the claim details and compare an ICD-9 to an ICD-10. There is no screen real estate changes. There's no graphical changes. It's all behavioral based on that date of service. So you'll notice here in our pre-October 1 date of service, to the left of my pink rectangle and the diagnosis table, some of my ICD-9s are without an ICD-10. However, that third one I've already mapped to an ICD-10. In the case of an ICD-9 claim, it could be mapped or not. Doesn't matter. We started storing ICD-10s a year ago, even though we weren't doing anything with them. So some of you may have already gotten ahead of the curve and started updating your 9s to your 10s. An ICD-9 may or may not already have the ICD-10 displayed with it. However, on the charge row level, the way you will visually see that it is an ICD-9 claim, the header says ICD-9 codes and the pointers are populating the ICD-9 code. So in that case of my third one, the asthma, even though my J45909 shows, notice on my charge row it brought in the ICD-9 493.90. Now taking this exact same claim after October 1, notice this time in my diagnosis table, every 9 is mapped to a 10. It is a requirement or you cannot save your claim and mark it ready to send. Therefore, on the charge row, the label is ICD-10, and this time the pointer is populating ICD-10 codes for every line, even though the ICD-9 remains present. So in billing, the hyperlink will always be present whether it has been mapped or not. And of course, this allows the biller both the ability of assigning the ICD-10 or changing the ICD-10. Maybe the physician has mapped it incorrectly, and the biller knows that a different code would produce a better reimbursement. So the opportunity is there to modify it or assign it before marking the claim ready to send. Now on the diagnosis table, the biller does have the H and the A buttons, which are similar in function to the C button that we saw in the assessment, meaning it invokes a pop-up of underlying master data. The distinction, however, on the assessment screen, when the physician chooses the C button, it opens up the system master file of complaints and the optional ICDs that have been predefined. Since that is a system master file in EMR, there's a hyperlink available within this pop-up, and the doctor is prompted to simultaneously update the master file if desired. Here on the claim side, the master file is not associated because it fed the EMR side. And remember, EMR is what creates the claim. However, the function is here in that it can open up a build history master. So at a patient level, it is a master file instead of at a system level. But it is a master of history and therefore cannot be modified, and that is why it doesn't support the hyperlink. You can still choose the value, as in this example, I am choosing the acute bronchitis, and when it populates my claim, it populates as a hyperlink. So I can change it on my claim level. If you do inpatient billing on UBO4, The admission diagnosis behaves the same as we talked about on our prescription screen, meaning the ICD-10 must already be mapped before you can associate it as the admission diagnosis. Therefore, there is no hyperlink here. We also validate at the claim level, same as we did in EMR. If you attempt to mark your claim ready to send without mapping the ICD-9 when it's after October 1, you will not be able to do so until you map it. It will validate for duplicates. Now, the duplicate validation is different on the claim level in that it's looking at the ICD-10 code only. It doesn't care about the 9 or the SNOMED. Now, of course, you do have the ability of creating new claims. There's 4 scenarios supported. Basic bottom line, date of service is what determines whether you're creating it as a 9 or a 10. Whether you're creating it new from scratch there at the top, or second scenario is when you're creating a copy of an existing claim with a new visit ID and date of service. Maybe I'm choosing an August claim and I'm now billing it for October. The August claim that I am copying is ICD-9, but now that I have populated a date of service after October 1, it's going to create as an ICD-10. If I create a copy of an existing claim with the same visit ID, if I'm creating that August claim, it will recreate as August again, meaning ICD-9. But after October 1, if I create a copy of an October claim, it will recreate as ICD-10. Now, one exception to that rule would be at a payer level exception when your payer's not ready for ICD-10. Workman's Comp has not been mandated to migrate to ICD-10. Otherwise, all payers, paper and electronic, do. Locally, however, some of your payers may not be ready. So you're going to be able to manage that at the insurance master level through the extra info button. There's a new flag called Not Ready for ICD-10. So as we see here in my case of ABC Insurance, I've clicked that checkbox stating ABC Insurance is not ready to accept ICD-10. There will be no disruption in your billing workflow because of this. The claims will automatically create as usual. It's just that the claim screen will give you a prompt. Now, this is not an error, this is an FYI, telling you we're creating the claim as ICD-9 even because the insurance is not ready for ICD-10. So even though the date of service says it should be ICD-10, we're going to put ICD-9s on it. Now, whichever time you're ready to rebill those claims, because it's time to get them processed and the payer says they're now ready, again, there's no disruption in workflow. You will not have to void the original claim, copy and modify it. You will simply remove that payer master flag, go under your claims processed, filter it to the ABC Insurance, select the claims you want to rebill, and then click the resend icon. Now, normally when you click that blue arrow, it is an exact rebill, like second request, and typically doesn't allow you to make changes. This is the exception to that rule. If the date of service is after 10/1, the payer master flag does not say they're not ready any longer, then even though it originally was an ICD-9, when you rebill it now, it will be rebilled as an ICD-10. Now, moving forward as far as program enhancements to support ICD-10 management. Initially, on the first one we're going to look at is on the IMO Search Screen. Locally, you can now decide which search tab is your default. You'll notice here in my example, I've got Preferred, Standard, Custom, and there is the new 4th tab called Drill Down, which we're going to look at in just a moment. But some of you may not have preferred codes defined. Some of you may use custom codes only, or the standard search is what you need to invoke, but it always takes additional mouse clicks and you feel that it's just not as time efficient. So now we've introduced this new property at the bottom that allows you to either hide these tabs if you don't want to use them at all, or at least resequence them in your preferred order. Now notice here the one exception to the rule as regards your hyperlink tool. This is the only screen that the hyperlink will go away once you've mapped it. We talked earlier how the hyperlink is retained on the other screens in case you need to modify it. At this level, however, since we are dealing with preferences that you've predefined or custom lists that you've customized, you will have already mapped it when you defined it as your preference or as your custom. Therefore, the hyperlink is not needed. Now, the primary enhancement here is the drill down tab, and this is a new feature on our standard search that expands the logic of that standard tab by, it's kind of a hybrid of the hyperlink plus the standard combined for the sake of you being able to drill it down to the specificity requirements of the diagnosis. So for instance, initially here in the upper left, that data entry field will be blank, and you can type in any ICD-9, ICD-10, or description, and then execute the search. Notice that when it populated the search screen, it matches what you searched on, whether it's the code or, in my example, the description of migraine. So this is where it's behaving the same as the hyperlink. The only difference is your direct data entering the value instead of having a pre-populated hyperlink. It is still reducing the values you have to search through, however. So the ICD-9, the ICD-10, the SNOMED in this case could be any combination that includes the word migraine. But had I entered 346.9 instead of the word migraine, I would only have that first option, the 34690. I wouldn't have gotten these other choices because they do not begin with 3469. So you can kind of play with this based on the root disease you're searching to determine the ICD-10 SNOMED combination much quicker than just having a generic search of thousands of codes that you have to scroll through. Now the way the drill down works is when it populates those examples, you're going to have two possible icons on the left margin. The first one here is the expand, where you can expand the code to display specificity criteria until you drill it down to the highest level, or the plus sign. The plus sign means that that diagnosis is as specific as it needs to be. If that meets your patient's conditions, it is good to go ahead and assess that on your encounter or bill it on your claim. So when you click the plus sign, it's going to populate that gray tab in the upper left called conditions. And from there, you're going to add it to your assessment or your claim. But first, we're going to look at the expansion. So we're going to click our expand arrow on the generic migraine. When you click this icon, additional tables are going to appear. It's going to push down all of the other values that populated from the filtered search and insert these tables. Now, in my example here of the migraine, I have 3 tables that showed up. Now, depending on the root disease, you may have 1 table or you may have 8 tables, as it's all based on that root disease, how far you need to drill it down. Some of them take into account the intractability, the presence, the status, the type, chronicity pattern, complications. So it's all going to vary as to how many tables populate here. The thing that doesn't vary, however, regardless of how many tables, is the behavior. In order to drill down to that most specific code, every time you choose a value in the table on the left, it is going to filter down the choices in the tables on the right until you finally get to that drilled down highest level. So as we see here for my migraine, I started with just plain generic migraine, but now that I've chosen it's menstrual, it's with status migrainosus, and it's intractable, now I have the most specific code with the plus sign that you see outlined in pink. This is now the code I can put on my assessment. So when I add it to that conditions tab by clicking the plus sign, notice here I've expanded my conditions to show you that in addition to the migraine, I've also assigned diabetes, I've also assigned asthma affecting pregnancy. When I click the OK button, all 3 of those diagnoses populate my encounter assessment. And notice that it brought in both the ICD-9 and the ICD-10. The ICD-9 remains hyperlinked if I realize I had chose the wrong ICD-10 at this point. Now moving into the billing side, some enhancements for ICD-10. We have some new scrubber check operands. So you'll notice there that you can build your scrubbers based on ICD-10 specific conditions. Keep in mind your ICD-9s are all still valid because the claim retains both the 9 and the 10 code. But being that the 10 is going to be a far different code, you may need to build new ones based on the 10, depending on your payer level. Bill filters accommodates 9 and 10, both at the claim level and at the individual code level, depending on how you need to filter your claim searches. Custom report layouts. We've added new fields. If you are using any kind of analysis report, maybe you need to know how your reimbursement has been affected from the ICD-10 transition. You can add both your 9 and 10 codes to your analysis report and get that information. Now, those are the behavioral enhancements. A lot of the other changes for this transition is really just in the regards of labels, tags, and other indicators on the screen. So aesthetic things. First of all, on the encounter level, on your patient band, we've inserted a new color bar, as you see there to the left of the patient's photograph, that indicates in red that it's an ICD-9 or orange if it is an ICD-10. That again is all triggered from that date of service. The tool tips on your diagnoses, whether it's past medical history, assessment, the claim, wherever we are displaying both the 9 and the 10, the tool tip will be reflective of the date of service so that you know which diagnosis actually applies. On the claim print tags, your CMS 1500 for paper claims, notice in cell 21, the ICD indicator will be reflective of either the 10 or the 9 edition, and the codes that the pointers populate will be accordingly. On the I button, you're going to have a label telling you whether it's a 10 or a 9. The railroad track icon will let you see if that claim printed or electronically billed as a 9 or a 10. When you go in to do claims preview or reprint, the label is going to be clear as to the claim that you're printing or resending. Tooltip going to show you which ICD went with that charge row. All of the history screens have been modified to now show ICD-10, both in EMR and billing. EMR also shows SNOMED. So those are the programmatical changes, both functional and aesthetic, from the transition tool, the hyperlink tool, and the new drill down tab. Now, before we wind it down here, here's a list of all of our vendors that are currently certified as of September 2015 with regards to lab, whether you're doing lab interface electronically with an HL7 interface, or you're just quite simply printing a paper requisition. These vendors are currently certified to accept ICD-10. Same thing for those of you who have practice management system interfaces. If your vendor's not present, please contact them and ask them to follow up with our interface services team. Now, for EDI clearinghouses, the good news here is that every client we have who is using our billing system live, all of these vendors are fully certified. So again, no disruption in billing workflow come October 1. Now, some of you may have been getting letters from the clearinghouse telling you you need to submit test claims. You do not. We have done the testing for you. So looking forward, as far as the deployment, the good news here, if you're an ASP Cloud user, you do not have to wait for the upgrade. You already are on the current version, which is version 3 build 2. As long as you're on Service Pack 163 or higher, you already have these functions available to you now after this webinar. If you're not sure what version you're on, you can click the I button, which is your help information, up in the system tray, and that will show you here the version and service pack. Now again, this is for cloud users. You are all 100% automatically upgraded. If you are a client server user, please contact your local IT administrator for details. Those have to be done through your local IT department and our update group. As far as preparation, this is at your discretion. If you would like to analyze your ICD data and then use those specific tabular reports for creating a crosswalk, start using these new tools, or just wait and do it as you go on the encounter level. It's totally your choice. As regards prognosis, support, and resources, our resource center does have a recorded version of this webinar. There's also ICD-10 specific modular videos. As far as human support, if you are a current client implementing, you have your implementation manager as a point of contact. If you're a live client that has already transitioned to technical support, we have a 1-800 number, we have a group email, and of course we have the live chat options. And then just as a point of reference, we also are giving you the website for CMS, their ICD-10 homepage. They've also got a tutorial page where they have published user guides, videos,